What is rehab or rehabilitation? My name is Fred Bagares, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab Podcast.
Every couple of years, there is a paper that comes out regarding interventional spine injections and its efficacy, talking about your classic epidural steroid injections, facet injections, radiofrequency ablation, things of that sort. And recently, a new article came out in the British Medical Journal discussing commonly used interventional procedures for non-cancer chronic spine pain. And the results essentially said that these type of procedures are ineffective, quote unquote. Pain physicians obviously got really upset because this is essentially what we do on a day-to-day basis. There's a lot of uproar, a lot of people starting to write letters to the editor, things of that sort. And I was talking with one of my colleagues about how this is an outrage, and the main concern is not only that it demonstrates from a research standpoint that the procedures we do on a day-to-day basis do not seem to make a long-lasting effect. That's number one. But number two, a lot of us feel that these injections are extremely helpful, and the research does not support it, so it gives us a little bit of cognitive dissonance, essentially. But lastly, one of the other major concerns is that insurance companies will typically take papers like this, and no matter how they're structured, how well they're designed, they will take the literal words and basically use it as justification for denial of care. And that's a big deal. It's not nothing, but again, my colleagues were really upset about this paper. It's just one other thing in addition to burnout and the administrative stuff that they have to deal with. And the last thing they needed was a paper with authors in the field basically finding a negative or reporting a negative study. And that doesn't obviously make us feel very good. But what a lot of people fail to remember is that this is not a new finding, at least from a research paper standpoint. They were doing similar studies like this 10 plus years ago. A big one came out around the time I was in fellowship and it had very similar findings. It was done in print. It was a very similar paper. They looked at essentially a pretty wide range of patients, pretty wide range of conditions, and found that these interventional spine injections are effective, but aren't necessarily better compared to other treatment options. The questions that triggered today's episode, are these tools truly failing, or are we failing to figure out how to make these tools work? So I'll say that again. Are these tools actually failing, or are we just failing as clinicians to figure out how to make these tools work? I've been doing these type of injections for 10 plus years. And I came from that generation of kind of old school bread and butter type procedures. When I talk with these new grads coming out, look at the new papers, there's a lot more technology out there than when I was in fellowship. And I never really picked up those procedures. Number one, and when you're an attending, you can do weekend courses, but some of these procedures, I believe, need more than just a weekend course. So I just never really felt very comfortable taking on some of these more complex type procedures without actually being in a fellowship. Sure, you can learn them on a weekend, but again, I tend to be a fairly conservative person. Didn't think it was the right choice for me. But again, I also was not really finding the need to come up with different tools. I see different populations, different ages, and the tools that I have seem to work pretty well. And if a new fancy tool comes out on the market, I do learn about it and I talk with people using it. It's interesting, but I don't really see how it fits in my particular practice. But as I'm talking to some of my colleagues, it seems like they have a different population compared to me. It seems that way. And they're like, oh, they'll describe the perfect type patient that is the perfect candidate for a vertiflex procedure or some discogenic procedure, spinal cord modulation, things like that. And I just never really saw that particular patient. I know they exist out there, but I always was able to find a tool that works for that particular person. And so I never really found the need to do more. And I'm not opposed to referring my patients to some of these procedures. But again, I just thought it was interesting because I see the same population that they do. They may see more complicated patients compared to me, but on the whole, I just seem to find a way to get people better. And yeah, that's that. One of my personal hangups with a lot of these studies is that you can pick any of these interventions, epidural injections, facet injections, ablations, things of that sort. These are relatively short-term tools. These are things that can work unpredictably. They can be very effective long-term, but at the same time, even in the best case scenario, they are expected to work for a relatively short amount of time. So we're talking maybe less than 3 months. Some people do get much longer effects. Some people it's a home run. But on the whole, when I give an injection to somebody, I set up the expectation that this is a short-term tool that fits into a bigger game plan. But when they do these studies, they compare, like, let's say an epidural injection compared to physical therapy. Let's just say that. And what they find is that the epidural injection is very effective for controlling acute pain, but at 12 months, people do roughly about the same. And the conclusion there is that, we'll see there's no significant benefit at 1 year. And that's true. And in my clinical practice, I find that to be the case. But at the same time, physical therapy is not meant to be a long-term solution either. Same in terms of like people going to physical therapy for about a year. People will go for 6 to 12 sessions. They'll feel better. But then if you measure them at about a year, the treatment effect also seems to fall off. But when people hear how it does against an epidural injection, they draw the conclusion that the epidural injection isn't necessarily better. And it's not. But at the same time, it has a very specific treatment effect and goal. It's not a magic injection that's meant to last 2 years. Similarly, 6 to 12 sessions of physical therapy can be super effective, but there's not a lot of treatment in the musculoskeletal world that will have a long-lasting effect for 10 plus years. So I don't think that it's a realistic. From a study standpoint, I think there's an issue with our overall expectations and how we interpret the actual data. These are short-term tools being compared to short-term tools. Now, interestingly, I did talk with a researcher, I'm not going to name them, several years ago, again, talking about epidural injections, facet injections. And I said, have they ever done a study where one group got an injection? At this point, it doesn't make a difference what kind. Let's just say any injection. And the second group got an injection plus physical therapy. And this primary author said, no, but that would be a good study. And that paper eventually did come out, maybe about 7 years after I asked that question. But I was just really shocked. That was not a study that had come out at that point. To me, anytime I do an intervention, it's usually coupled with something. And I think that's where people tend to get stuck, is that particularly with people being more interventional, they like to just do procedures. And from a patient standpoint, they just like to receive stuff. No one really likes to do extra. But when you treat a potentially chronic problem like spine pain with short-term tools, you can only guess what kind of result that you're going to get. It's going to be short-term relief. It's never really going to do it for forever. The real magic happens when you take the short-term tool, get yourself comfortable so you can do other things for a long-term solution. Things like generally living a healthier lifestyle, sleeping better, eating better, keeping our weight down, learning different ways to use our back, learning our personal environments in terms of workspace and recreational space. Sometimes we have to adjust the things in our spaces to be in a better position so it doesn't bother our back. But realistically, humans don't really do that. We just say, hey, give me an injection. I have pain. Give me an injection. Make it go away. Now that it's gone, I don't have to adjust anything in my life. And again, that's a very short-sighted way of receiving the injection. But even from a clinician standpoint, it's a very short-sighted way for us to treat our patients. And that's where I see why these papers come out, is that spine pain is one of the most debilitating conditions in the world, but it's also one of the most expensive. The cost of time off, injections, physical therapy, surgeries, post-operative recovery, complications from surgeries, complications from just about anything, it's super expensive. So I understand why these type of procedures essentially are on the chopping block. Every year, there is some sort of cut in reimbursement with respect to interventional pain. There's more of these negative studies in the clinical community. Their main response is just to write to the editor and put this retraction, so on and so forth. And again, they're chipping away at the wrong problem. I've been practicing 10 plus years, and I do see these younger grads coming in and they're just super interventional. They're not really working on all the other long-term solutions. And so what they end up doing is that they learn the bread and butter, then a new fancy technique, interventional spine technique comes out. Again, it's a short-term tool. It's a short-term tool. Even some of the minimally invasive spine stuff, the medical devices that are going into the spinal column, the non-surgical solutions, but these minimally invasive solutions, it's the same thing. Like, you put the device in, it helps temporarily, but if you don't make all these other changes, it tends to just land in the exact same spot at the 12-month mark. Overall, I think it's a really good question as clinicians to ask ourselves, are these tools actually failing? Meaning, is there really is you take intervention X, you test one group, you test the other group, one group gets the treatment, the other one doesn't get the treatment. Group X that receives the treatment has a short-term benefit at 3 months, but then long-term, they wash out. So did the tool actually fail? I would say probably not. If you had acute symptoms, acute pain in that 3-month period, maybe it did its job. The problem is that what happens from not months 1 through 3, but from 4 through 12, what happens in the other 9 months? That's really the goal. I think as clinicians, we keep waiting for papers to show that our short-term tools actually last lifelong, and that's just completely unrealistic. If anything, I do hope that people are working at adding to these tools, not necessarily just learning new shiny ones. And maybe I'm just a lot more experienced now, but I see a similar phenomenon in some of the older surgeons. These new techniques come out, but at the end of the day, you talk to an older surgeon, they can tell you what's going on. They can tell you, yeah, that's going to work, that one's not going to work, just because that they know that. Again, I'm not a surgeon, but I have talked to them over the years. The older surgeons know that the secret isn't necessarily the surgery. It's knowing who not to operate on. And the ones that you do operate on, you know that these are the most well-adapted patients. So these are almost like a quote-unquote perfect patient that's going to do lifelong, because they have the skills not only to survive the surgery, but they know how to manage their backs from months 4 through 12. So it's not necessarily they're not actually managing the post-operative period for the rest of their life, but they have developed a sense on what kind of patient profile can take care of their backs, and that's who they pick to operate on. It's a similar thing with interventional spine injections. It does also come down to patient selection. But selecting the best person to receive your treatment, I don't want to say it's easy, but that's a relatively small population. There's a lot of people that need more than just the injection. And so I think that the goal of the clinician is not to find the perfect patient. It's to learn how to manage all the full spectrum of complications or complicated or maladapted patients. Those are the ones that need the most assistance. And that's, again, part of my drive to do this podcast is to raise awareness that there's a lot of information out there. Yes, the injections are a short-term solution. Yes, surgery sometimes is a short-term solution. You have to find someone who is going to walk you through months 4 through 12, not just someone who's going to do the injection, just do the surgery. The goal to reclaiming your body, reclaiming your independence, it happens way past the intervention. So just something to think about. Are we failing to use these tools correctly, or are we failing to find ways to use these tools successfully? Anyhow, thanks again for listening. I hope you guys enjoyed this one. If you have any questions, you know where to find me. Take care.
Thank you for listening to the Talking Rehab podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.